Our ultimate goal as a field of thoracic oncologists and oncologists in general is to start better understanding how we could apply local therapies in the management of metastatic diseases. And that's metastatic diseases across all primary cancers. We think there may be a role. And the subset of patients that we are ultimately looking at first are those patients that have what we call oligometastatic disease. And those are the patients that have limited volume cancers, meaning their cancers have spread to only a limited number of sites. And in that cross-sectional window of time, we think that those patients' tumor biology may not allow those diseases to have evolved to spread to other more increasing number of sites. So with a limited number of sites, we think that local therapy will help. And that to describe that setting where there's only a limited number of sites that local therapy may help, Wexelbaum and Hellman coined the term, or really popularized the term oligometastatic disease in the 1990s. So when we think about when we can apply local therapy, we can really apply local therapy to patients with the quote-unquote oligometastatic disease in consolidation, which means after they've received their first significant amount of first-line therapy. And in those scenarios of consolidation, patients could have been diagnosed with limited metastatic or oligometastatic disease at diagnosis. And by the time that they came around to receiving local therapy, they still had the same number of sites of disease. So it looks like the systemic therapy temporized the disease and prevented it from becoming or growing in a more number of sites. How we describe oligoremnant disease, however, is those patients that may at diagnosis have had polymetastatic disease, meaning more than 3 or 5 sites of metastatic disease. Usually this is patients who may have had 8, 9, 10, 12 sites of metastatic disease. And then after they received their first-line systemic therapy, they started actually having some of those lesions resolved to the point that they were not targetable by local therapy. And so by the time that our consensus about consolidation came around and the use of local therapy in consolidation, what once was 12 metastatic sites is now just 3 metastatic sites that are residual or remaining. And that's what we view as oligoremnant disease. So one is a oligometastatic state that existed at diagnosis and persisted to the point that local therapy is utilized. Another is patients who had polymetastatic disease and they were induced into an oligometastatic state, or what we call an oligoremnant state, by the effectiveness of the systemic therapy. And so that's kind of the distinction between a patient who's had oligometastatic disease from the get-go and one who has oligoremnant disease at the time that a local therapy may be offered.